Good evening, everyone, and welcome. I am Aaron McKinney. I'm the General Manager of High Arts, and we are so excited that you are joining us this evening as a part of our March commitment to health and wellness. We are here discussing the COVID-19 vaccine. So we are excited that you are joining us tonight, and I hope that you all have questions prepared. But I'm so excited to introduce a friend of mine. Her name is Dr. Risha Irvin. And Risha is an assistant professor at Johns Hopkins School of Medicine in the Division of Infectious Diseases. She is also the Associate Vice Chair for Diversity and Inclusion for the Department of Medicine. Additionally, Dr. Irvin has been working with the COVID-19 Prevention Trials Network on community engagement, both locally and nationally. And she is married to Dr. Nathan Irvin, who is an emergency physician at Johns Hopkins. Also, which is not part of her bio, Risha is a proud graduate of Southside High School in Greenville, South Carolina. And that's how I know Risha. We went to high school together in South Carolina. Just before we get started, like I said, I'm Aaron McKinney, pronouns he, him, his. I am calling from the land of the Lenape people, also known or now known as Brooklyn, New York. And I am a caramel complexion, black male, high top fade, faded sides, beard. I have on a cream sweatshirt that says "Have Mercy." And behind me is a cream wall with a colorful painting. And to my left is a green plant. So once again, thank you. I would also like to thank Mike Barrios, who is here with American Sign Language interpretation. So we greatly appreciate him. And once again, I want to introduce you guys to Dr. Risha Irvin. I'm going to take myself out and I'm going to let Risha take care of the rest. So welcome, Risha, and thank you so much for having this information prepared for us.
Thank you so much for having me. Really excited to be here with you all this evening to talk about COVID-19, healthcare disparities and vaccines. I do want to say before I get started that, this last year has been very taxing, I know, on all of us. I sit in an infectious disease division where we've dealt with the pandemic firsthand, but I'm also married to an emergency physician who kind of was also on the front lines. And so very much kind of understand kind of everything that's happened in terms of what's going on in terms of the work with COVID-19 in the healthcare workforce. So thank you so much for having me. I did want to also just describe myself for those who may be watching, but I'm an African-American female with dark brown skin sitting against a gray wall. So I'm just going to pull up my slides now. I think everyone can see my slides. So I'll just, sorry, 1 second. Okay. So I'll just get started. So we're going to have a conversation about vaccines this evening. I do want to acknowledge I sit in a division of infectious diseases. I'm not a vaccine researcher and actually work on HIV and hepatitis C most frequently, but was brought into COVID-19 work with our vaccine trials team at Johns Hopkins, primarily to work on kind of some of our community engagement strategies. And I've been doing that in Baltimore locally, and then also with community engagement on the national level.
Risha, we can't see the slides yet.
Oh, I'm sorry. Let me see what's going on. Can you all see now?
Yes.
Okay, sorry about that. There we go. Okay, so moving on. So first, what I want to talk about is kind of what places you at risk for severe COVID-19 disease. And what we know is those factors are older patients, male, having hypertension, so high blood pressure or heart disease, diabetes, so problems with your sugar, obesity, chronic lung disease, cancer, and chronic kidney disease. And these factors are important because then when they were launching the COVID-19 vaccine trials, it was important to make sure you have a wide array of individuals and that you capture individuals with these different characteristics as well to see how you can prevent COVID-19 disease. I did want to take a moment and pause and talk about how COVID-19 has disproportionately impacted people of color. And we know that pertains to both cases, hospitalizations, and death rate when we talk about COVID-19. And do want to draw your attention to kind of the death rate when we look at American Indian or Alaskan Native, about 2.6 times that of white non-Hispanics, and then African American and Black and Hispanic Latino, about 2.8 times that of white non-Hispanics. So we're talking about rates almost 3 times that of white non-Hispanics. And I think, you know, for those in the healthcare field and beyond, that should call us to arms to say we've got to do something about this situation. I always like to take a moment to talk about kind of why we see health disparities. And health disparities are not at all new. We see them in almost every chronic disease, every infectious disease that we've studied. And so we've known about this. The big thing is that COVID-19 has put a spotlight on these health disparities again. And so the reasons for this that have kind of come out in some of the work that's been done are, you know, some of the differential risks that we know more kind of Black and brown people are working in jobs where they were on the front lines. And when everyone was able to work from home, many people were not. And so they were exposed to COVID-19 more frequently. There's a long history in our country of differential access to healthcare, who does and does not have healthcare. And we know in Latinx immigrant communities that many of them are excluded from public safety net programs due to immigration status. There's also, as many of you know, a long history of structural racism in our country, and living in higher density neighborhoods puts you at higher risk of contracting COVID-19. This has resulted from things such as redlining in our country, where African Americans could only live in certain areas. And so more people were condensed into smaller spaces. And again, that puts you at higher risk of things that are infectious. Studies have shown that there are fewer hospitals in Black and brown neighborhoods. And then we also have to think of other social determinants of health in terms of housing, poverty, and comorbidities. There's many factors kind of at play, but did just want to highlight some of these. Again, as many of you know, in terms of how we slow the spread of COVID-19, wearing a mask, you're staying at least 6 feet apart, washing our hands and cleaning and disinfecting. But another part of that is, you know, how we get out of this pandemic. And that's kind of where COVID-19 vaccines come into play. So as we think about vaccines and why they're important, this kind of diagram basically just shows that if people have COVID-19, it can just spread much faster when you have a naive population without vaccines. But when we reach herd immunity, which typically is thought to be around 70 to 80% of a population, depending on the disease, this kind of fluctuates, that you can essentially stop the spread, because while people may be exposed, if they don't contract it, then they're not kind of passing that on to multiple other individuals. And so we're able to limit kind of the spread in the community. So now I'll go into COVID-19 vaccines. I'm primarily going to talk about the 3 vaccines that we have emergency use approval for. There is a 4th one that's going to go before the FDA soon, but we'll focus on the 3 that have been approved. But first, kind of just thinking about the goal of a vaccine. The reason we want a vaccine is to develop an immune response, basically to prime your body to fight off a virus or a bacteria. And it helps your body to develop a memory. So if it sees that infection again, that it knows what to do and how to fight it. It's not your first time seeing it. So you want to protect against kind of the disease and having any symptoms, but also protect against ever even having the infection. And so those are the overall goals of us producing a vaccine. So what you may have heard in terms of the Pfizer and the Moderna vaccine, they are mRNA vaccines. What this diagram basically shows is that you have what we call kind of this message or messenger RNA. And those vaccines put it inside a fat molecule that you're able then to take inside from the COVID-19 virus. It doesn't have any live virus, but has a spike protein on the outside inside this fat cell. And then your body can recognize that spike protein if it ever sees it again. I know there was a lot in the media about mRNA vaccines being new and people saying the technology was new. So it was actually new in terms of this is the first time it's been marketed in a vaccine in this way. But mRNA being used in treatments actually is not new and had been worked on for many years and was common with cancer treatments. But now that technology was applied to vaccines. So the first vaccine that got emergency use approval, as you may remember back in December, was the Pfizer vaccine. So it is this mRNA vaccine, which is inside what we call the lipid nanoparticle, which is just a kind of a fat coat that allows you to take it inside. It's 2 doses, 3 weeks apart. It's the one that has to be stored at extremely low temperatures. In the vaccine trials, over 40,000 people were enrolled. And I think important to point out that 10% were African American, 26% were Hispanic Latino, and 21% were 65 and older. What we know from the data coming out in real world data is also panning this out is that it's 95% effective starting 7 days after the second dose. And 94% effective in adults 65 and older. And again, this was approved back in December, and it starts at persons 16 years and older. The next one that was approved was the Moderna vaccine, and this one came out of the National Institutes of Health. Very similar to Pfizer in that it was still this mRNA vaccine, but it's 2 doses 4 weeks apart. It does have to be stored in a refrigerator, but not as cold a temperature as the Pfizer vaccine. About 30,000 participants were enrolled in the Moderna trials. And again, around 10% African American and around 20% Latinx. It's been shown to be 94% effective starting 2 weeks after the second dose. And it's for those 18 years and older. We always like to tell people after vaccination, you will likely have some side effects, but this is normal. This is your body mounting a response. Things that are common are pain at the injection site, some redness and swelling there. Other things that are common with other vaccines as well are fatigue, headache, muscle aches. These have been shown to all be worse after the second dose, and that's because now your body has seen this spike protein before, and it's responding to seeing it again. And so your body is mounting a response against it. These side effects have been shown to be more pronounced in younger adults versus older adults. The next vaccine that was approved for emergency use approval, which you may have heard a lot in the news, is the Johnson & Johnson vaccine. And it uses a different type of technology. And this was very common in vaccines prior. So it takes the same spike protein, but puts it inside another common cold virus, the adenovirus. And this is something that has been done for many years in terms of vaccine technology. This study enrolled about 45,000 individuals, and it's a single dose vaccine. So 1 dose. They are looking at what would happen with 2 doses as well. Side effects did occur in most people after 1 dose, and they were again greater in younger than older adults. Some of the same symptoms in terms of the pain at the injection site, and then systemic, looking at fatigue, headache, muscle aches, nausea. And then fevers do also occur in some. When we talk about efficacy of this single dose vaccine, so what you may have read, the efficacy is a bit different. So 72% in the United States, 66% in Latin America, and 57% in South Africa. Now, these numbers are different primarily due to different variants that are circulating now. One of the questions that we often get asked, well, why are these so different? We do have to remember that when Pfizer and Moderna were approved, their studies happened earlier in the year, that we didn't have all of these circulating variants at that time. So it's very hard to directly compare the Johnson & Johnson vaccine to the Pfizer and Moderna vaccine. What we do know from their data that it's 85% effective in preventing severe disease, and like the others, 100% effective against hospitalization and death. And so what I tell everybody is what we should most care about is that number. Is it preventing hospitalization and death? Because that's the endpoint that we most care about. And all of these vaccines do that. And so people often ask, which vaccine should I get? You really should get the first vaccine that is available to you. One of the other benefits of Johnson & Johnson, particularly from a public health perspective, is that it's just one dose. So for many people, not having to get off your job and just being able to do that one dose and not having to arrange to get off a second time, or if we're going out in the community and vaccinating and worrying about follow-up of people, it's easier just to give the one dose vaccine. The other question that we get a lot is about the COVID-19 variants. You may have heard many of these have been emerging now in the United Kingdom, South Africa, Brazil. And these, we live in a world that is very much connected now. So they start one place and it spreads all over. And so these variants are expected to be essentially everywhere, and we have to prepare for that. So what we do know is that viruses constantly change through mutation. New variants, just almost with everything, appear over time. It does appear that some of these variants spread more easily, which may lead to more cases of COVID-19. And it could strain the healthcare system, which makes it more important that we get as many people vaccinated quickly before these variants take hold. What we don't know is how widely the new variants have spread. How the disease caused by the new variants differs from currently circulating variants at this time. Preliminary data coming out of the United Kingdom suggests that the variant may be more transmissible and may be linked to higher rates of morbidity and mortality. How these variants may be working with existing therapies, we don't know. What we do know is that the COVID-19 vaccines will offer you protection against these variants. What the efficacy is for each variant, we don't know, and those things are being followed up and tested. It also brings into play whether or not at some point we may need boosters to COVID-19 vaccines, and those are things being studied as well. So who should get the vaccine? Really everyone who is eligible. We fully acknowledge that there's limited supply, but this should increase over time. And it actually has been, as we get more vaccines approved and as the government cuts deals with more and more vaccine companies, vaccine eligibility has been opening up. Every state has kind of determined their own eligibility though. So it's important to check frequently. And the vaccine should be free to you. For those with previous COVID-19 disease or illness, you should still get vaccinated because we don't know how long you have protection from COVID-19, but you should not get the vaccine during your actual illness or while you are in isolation or quarantine. So definitely do not get it if you're still having any symptoms of COVID-19, and discuss it with your physician or other clinical provider. Now, when you had COVID-19, if you received particular treatments that are called monoclonal antibodies or convalescent plasma, you should wait 90 days after you receive it to get vaccinated so it doesn't interfere with the immunity to the vaccines. For immunosuppressed individuals, people who are immunosuppressed were not included in the trials. However, the vaccines are expected to be safe. What we do know is efficacy may be decreased if the immune response is not as good, but any protection is better than none. And there are current trials going on with people now on different types of immune suppression as well. The other questions that have been come up in some of the information that has circulated on social media is about kind of pregnancy as well and reduced fertility. None of that has actually been seen in the trials at all. And actually, in terms of the vaccine movement, the issues with fertility have actually been used as attack mechanisms against multiple vaccines before. And as soon as these kind of rolled out, that was also applied to COVID-19. What we do know is that the initial studies didn't include pregnant women, but data now suggests that vaccines are safe in pregnant women. You may have heard some of the news studies actually coming out today that they were releasing on this topic. There's also no known increased risk to pregnant or breastfeeding women, and studies suggest that vaccinated women can pass on antibodies to their newborns while breastfeeding as well, so giving the newborn increased protection. What we do know is that the risk of COVID-19 diseases is higher in pregnant and breastfeeding women and can result in poor outcomes. What the CDC currently recommends is that pregnant people who are in a group that is recommended to receive a vaccine have the choice to be vaccinated, and they should talk to their healthcare providers about this as well. In terms of children, as mentioned earlier, the Pfizer vaccine is licensed for those 16 and above, assuming they're in one of the priority groups in your state that allows them to get vaccinated. Moderna is only for 18 and older right now. We don't have any vaccines for those under 16 because those studies are ongoing. So the trials for children 12 and older are occurring. And then actually the trials are either planned for 5 to 12 or some of those have actually launched as well. One of the things, you always think about in terms of vaccines is just continuing to monitor safety. So there were the initial studies, and they're tracking all of those individuals, but there's also additional tracking going on through the CDC to determine what happens now as we've rolled it out broadly in terms of public health. And so continued tracking is going on. And these are some of the mechanisms. If any of you have been vaccinated, you may have heard of Be Safe, which is your after vaccination health checker, where you can report any symptoms. And right now, what they're seeing in terms of all of the reports are the same things that we're actually seeing in the COVID-19 clinical trials. So who should not get the mRNA vaccine? So that's the Pfizer and Moderna. If you had an immediate or severe allergic reaction after any previous dose of an mRNA vaccine, if you have an allergic reaction to polyethylene glycol or polysorbate, so that is in some of the prep for like colonoscopies and laxatives, for instance. So if you have kind of an allergic reaction to those, and if you do have these, you should talk to an allergist about them. Anyone with an immediate allergy to vaccine, injectable medicine, or any history of anaphylaxis should wait 30 minutes after the vaccine or consider talking to their doctor first. Most people have to wait 15 minutes after their vaccine and be monitored. Allergic reactions after vaccination. So severe allergic reactions or anaphylaxis can occur after any medication or vaccine. With Pfizer, it's been about 1 in 200. With Moderna, it's been about 1 in 350,000. We're still, Johnson & Johnson was just approved recently, so data is still pending on that. Again, for people with any type of history of reaction, they should wait 30 minutes, and it's 15 for others. There should always be an EpiPen for anyone that has a history as well of allergic reaction. We also, I think it's very important for science and medicine to always be transparent about what we do and what we don't know. So these are some of the things that we don't know. We don't know how long protection will last for these vaccines. It is possible that we could need boosters in the future. So we don't know if we'll need those, especially with the variants. So that is something that's being studied. We don't know fully if these vaccines will prevent asymptomatic infection. So just because you don't get sick enough and have to go into the hospital, could you have asymptomatic infection as well? So that is still being studied. There are many subpopulations, obviously, in our country. And so there are additional studies and data being collected so we can know more about that. And we don't know if these vaccines prevent transmission of COVID to susceptible individuals. And so those are things being studied as well. So just want to thank the group, our vaccine scientists at Johns Hopkins, because they've been very helpful throughout all of this. And then I'm happy to take any questions or hear your thoughts on COVID-19 vaccines as well.
Thank you, Risha, or Dr. Irvin. We do have a couple of questions, so I'm going to put them up on the screen as well. So one of the questions, if you have one or more of the comorbidities, how much more likely are you to be hospitalized or die from COVID?
So it varies greatly. So there's not like a fixed number that we can say, because, you know, there can be an interplay of factors. But these are the things that we know put you at higher risk of having poor outcomes with COVID-19. So essentially the recommendation is, if you have any of those, then you should take extra precautions to prevent yourself from getting COVID-19. And also, those are the reasons that many of those groups have been prioritized in terms of getting the COVID-19 vaccines. So it's very important in your state to check, because many of these things and comorbidities appear on the list to make you in a higher eligibility group for COVID-19 vaccines.
Thank you. Next question. Does 95% effective mean that there's a 5% chance you'll be infected with COVID or be seriously impacted if infected?
Sure. So yes. So the vaccines, when we say kind of effective, they're effective at you not having symptomatic COVID. So as I said before, we don't know fully kind of what it means in terms of asymptomatic infection. For instance, if you can have a low level kind of disease and be able to transmit that, but they're effective at preventing symptomatic infection and then preventing hospitalization and death, which I think are the major things that we should be looking at. But additional studies are going on to look at some of these other factors as well.
And I know you addressed this briefly. If you have tested positive for COVID-19, is there a time frame that you have to wait to be vaccinated?
Yes, so this actually just recently changed. So initially the CDC was saying wait 90 days. And I think the reason that they were saying that was initially because if you had COVID-19, some people were being treated with monoclonal antibodies or convalescent plasma. And the thought was, if you had those, you should wait 90 days. And so they made a blanket statement about everyone if you had COVID-19. They've recently changed that and removed that language. And now it just says, if you have COVID-19, essentially don't get it while you're actively infected or having symptoms, but after you recover and then get the vaccine.
And how long are vaccines good for? Some people have heard 3 months to 2 years, and apologies if the person missed this because they did have to walk away. I know you talked about this in your presentation as well. Yeah, but no, it's a good question. And, you know, so the data's still out on this, so we don't know exactly. You know, they've been tracking the initial people who were in the vaccine trials, and so far their bodies are still making antibodies and would still be able to fight off COVID-19. So, you know, we do think there's some durability. I think, you know, more thinking about on kind of how many years it will be durable. I think what we don't know is now with all of these variants popping up, if we will need like a booster shot at some point. And that's the part that we still have to research more. But, you know, a part of answering that question is tracking these people who were in the initial studies and see how they perform, which will help guide what the rest of us will need to do in terms of getting booster shots in the future. And the next question is very important for those states that, or, you know, those locations that are, you know, rationing out the vaccine. How do you balance this tension of not wanting to take someone else's spot who may be more at risk? Should we expect the supply to increase and take the first vaccine appointment we can? Yeah, you know, it's hard. I think, you know, initially, you know, when we were talking about January and kind of February, you know, there was a lot of focus on healthcare workers and nursing homes. And then many states started with 75 and over and 65 and older. And I do think it's really important that we make sure that those who are elderly get vaccinated. And that's really important.
Now many states have started to open it up more where, they're looking at age, but they're also looking at a lot of these comorbidities. So in my state, for instance, I'm in Maryland, and if you have, diabetes or any other heart conditions or lung conditions, you're now eligible for the vaccine. So I don't think people should feel like they're taking somebody's slot, because you're also at risk, particularly if you have any of those comorbidities. And so, and now vaccines in many places are starting to roll out at pharmacies and other places. And so if there are appointments available, I do think people should be more inclined to take those, particularly if you have any comorbidities. I do think it's also falls on all of us, though, to help other people in our lives get access to the vaccine. So if you know people who, may not be as computer savvy, helping them get signed up. I've done that for a lot of family and friends and just people that I've met through work or other places, to make sure that they have access to vaccines as well, because I'm particularly worried about disenfranchised and marginalized communities and people not having access. And so I do think we all have to kind of work to make sure that happens. There are a lot of great programs going on, in many states now. And I know New York and DC and other places have done that as well, where, a lot of the things we're looking at now is how do you get vaccines out in the community? And a lot of that means, taking mobile vans out in the community and vaccinating people. Setting up, we're doing a lot of partnerships with churches to do vaccination clinics at their churches, and doing those things with community-based organizations and meeting people where they are. We also can't always expect people to make it to the healthcare facility or to the pharmacy. At this point, we need to take it to where people are. And so I think anything that people can do in terms of advocacy around those things is really important too, as we think about COVID-19 health equity.
Thank you. Is it recommended to still get regularly tested for COVID-19 after you have been vaccinated?
No, so they're not recommending regular testing once you've been vaccinated for COVID-19. Even if you know of an exposure, they're saying that you shouldn't get necessarily tested unless you start being symptomatic from COVID-19 if you've already had the vaccine. So you don't have to worry about kind of regular testing anymore.
What is a good incentive to get the vaccine for young people who aren't particularly concerned about getting the virus and are wearing masks or practicing social distancing regularly, or who aren't wearing masks or practicing social distancing?
I think that's hard. And that's one of the tensions that we have, that there are elements in our country who, may have not been as impacted by COVID or may not be as worried because they don't have some of the risk factors. So how do you talk to people about why they should get vaccinated? And I do think, in public health, we have to do a better job about messaging. And a part of that message is, if we're not all in this together, we're not going to get out of this. And we're still going to be living with restrictions. And so, it's not just about you and kind of your personal health, but it's also about your grandparents and whether or not, you go to spring break and bring COVID back to your parents or your grandparents. And while we know that, the risk is less in terms of young people having poor outcomes, there still are people who are young and kids who have had poor outcomes, including, being in the ICU and also death. So it still does happen. And if you're that person, it doesn't matter what the statistics are because it happened to you. There are also people who have long haul symptoms from COVID-19. So it's the acute illness. But then there's also some people that are having symptoms months later, and that can happen to young people as well, and other factors that are associated with COVID-19. One of my cousins in her 30s had COVID and actually made it through the illness, but then developed pulmonary embolisms, which are a complication of COVID-19. And so that can happen. She ultimately ended up being okay, but she was hospitalized in the ICU to deal with the pulmonary embolisms. So I think we have to, think about kind of all of the consequences of COVID-19, but also have to view this as a public health matter that we've got to all work on this together.
As a medical professional, what questions aren't we asking? What are you thinking about, or what are people talking about that will make to the that will make it to the public in the coming weeks?
Yeah. So I would say, the big conversations we're having now are mostly about COVID-19 health equity, and what we call immune inequality. If you've seen some of the data coming out in terms of Black and brown people not being vaccinated at the same rates as white Americans, to me, that's concerning and it's an outrage. I think some of that has been attributed to vaccine hesitancy. And I fully acknowledge that there is vaccine hesitancy in Black and brown communities, but we can't let hesitancy be the only story, because there's also a story of accessibility, and where the vaccines went and where they were shipped to and what neighborhoods they were shipped to first. And so I think it's two parts of the story. So we have to demand access, and that every community should have access to the vaccine. And then it's upon medical professionals in the public health community to also address hesitancy and address it directly in terms of the history in our country of medical and scientific distrust, because that is real. We have a long history of segregation and many things that have happened in terms of science that should not have happened. And so we have to be honest and transparent about that and talk to people about their concerns. I will say we've been doing a lot of work in Baltimore in terms of talking to many Black and brown communities. And what we found is that many people had questions that they wanted answered, but when they got those questions answered, they wanted to get the vaccine. But people have to know that any question that they have is okay, and that people are going to answer it honestly, and that many people wanted to hear from physicians and other clinicians that looked like them and have those people tell the story to them. And so that's how we've been working on things. And so, we've had people who, came into something somewhat hesitant, got their questions answered, and they were ready to get the vaccine. But then the issue was accessibility, and just the cumbersome systems of trying to get on these lists to get the vaccine, and people getting frustrated. And so we've had to work with a lot of our patients on that. And many of us have used our personal emails to get people registered, because, some people don't have email. And so I think those are the things that, I worry about now, are just immune inequality, because, if white Americans get vaccinated and Black and brown people do not, and the vaccine is not accessible, then we'll just see these disparities continue to grow. And that's something that should outrage, I think, us all.
Great follow-up question. A lot of people are afraid of the vaccine. Why? What do we say to them to let them know that it's important to get?
So I think, there's been, vaccine, I'll say, hesitancy growing in our country for many years, for many different reasons, and people have different reasons behind that. But I think, we have to, one, be transparent about what we're doing and try to break down vaccine science. And so I would hope in most communities that people are organizing and trying to find community forums where they can talk to people about vaccine science in a digestible way, because it can be scary. And, you hear, well, there's new technology and they want to put it in your body. And so how do we talk to people about what the science is, how long the science has been going on, and then answer people's questions about what we do and what we don't know. I do think we also have to talk to Black and brown communities about the disproportionate impact that COVID-19 is having on us, because, some of the studies are suggesting that, 50 to 60% of people in Black and brown communities know someone personally who has died of COVID. And so it's something that's real. And so how do we prevent that? Vaccines aren't the only answer, but they're a part of the solution to us getting out of this. And so I think we have to have very frank and honest discussions with people. But, I think people, when I talk to, people I'm close to, why some of them have been afraid is just kind of the history of experimentation on Black and brown bodies and not wanting this to be something where they were being experimented upon. And so being able to talk to them about that. I think also that a lot of people feel more comfortable once they know someone who has gotten vaccinated as well. And so people, if you're comfortable sharing your vaccination status after you've gotten it, and talking to family and friends about that, I think that makes a large impact as well.
Speaking of questions, if you have a primary care doctor, can you ask them your questions about COVID, or where can we go if we have more questions?
Sure. Yeah. So I think your primary care doctor is a great place to start. There's also a couple different resources that I would recommend, and I can send those maybe later. I don't know if those can be sent out to the group, but there's a great vaccine frequently asked questions on the New England Journal of Medicine site. If you Google New England Journal of Medicine COVID-19 frequently asked questions, they have a lot of these things listed that I had in my presentation, but they have answers to those. It's a great site. The Centers for Disease Control and Prevention also has a lot of great information. What I will say is that, because, COVID-19 is novel and new, there are things that do change. And so the other thing I've tried to be very mindful when I talk to different community groups and tell them, what I say today, things may be a little bit different, in another month. For instance, when I was saying that, if you have COVID at first, they were saying, wait to get your vaccine, wait 90 days. And then recently that guidance was removed as they collect more data. And so things will continue to be updated as more data is collected so we can offer more guidance. And I know, for instance, many people want to know, how long these vaccines are going to last and if we need boosters. And, hopefully that will be answered in the next few months. And so that we can give people guidance on that as well.
What do you wish that we, the general public, would understand? What do you find yourself saying over and over? Because I know you've done a lot of these conversations. What's something that you find yourself saying over and over or answering over and over?
Sure. I would say the biggest concern that I've gotten on community forums or in text messages from friends and family, the fertility issues have been circulating on the internet a lot in terms of saying it affects either a woman or a man's fertility. There is no data whatsoever to show that. The other thing we've seen a lot on social media is that people say that the COVID-19 vaccines can get into your DNA and morph your DNA and kind of change your cells. And that's actually also not true. The vaccines don't integrate into your own DNA. And the fat coat that I showed you actually breaks down very quickly. So your body actually destroys the materials very quickly. The vaccines just help your body recognize that spike protein, but then they break all the particles down. So nothing gets integrated into your DNA.
We have one more question. I'm trying to transfer it really quickly. What is the percentage of people who had COVID and have been reinfected?
So that changes frequently. We don't have good numbers on it because a lot of people actually, if they're reinfected, may not have a severe disease and may not come back into the hospital. So hard for me to give you a number on that. It does happen, but we know it's pretty rare. With these additional variants, we could see it more, but it's pretty rare in terms of people being kind of reinfected with COVID after you've already had it. And that's mostly because your body knows how to fight it off. The issue is how long that immunity actually lasts to prevent you from getting COVID again, which is why people still need to get the vaccine.
I think that was our last question, Risha. Dr. Irvin, I'm so sorry. Thank you so much for this information. This was a very robust conversation and it was much needed. So we greatly appreciate you taking out time and presenting this information and answering questions for us. And again, thank you, Mike, for signing for us. We greatly appreciate you being a participant in this. We have been, like I said, focusing on health and wellness for this month. We still have a few conversations happening. We have a conversation happening on Tuesday with our marketing associate who has been talking about rest. So she has been taking a nap every day for the month of March and seeing how, and also she's been streaming it. And so people can log in to see her take a nap every day. But it's also a comment on, how we've been, how our sleep has been, impacted by all of the trauma, how we think about surveillance in this digital age. And we also have a conversation about Black femme labor, Black and brown, or people of color, Black femme labor, and that will be on April the 8th. And so we have a lot coming up. We also have our regular programming, so you can always go to our website, which is www.high-artsnyc.org to find information. You can also visit us on Facebook, IG, and Twitter at High Arts NYC to see any of the information. This conversation will be up on the on our social media, and it will also be up on our website. So you can definitely, visit us. Feel free to make a donation because it does take donations. We are a nonprofit organization, and so it does take donations to continue to keep this work going, our performance work, and also to have these panels that we have to bring you information. So I think I've said enough. Thank you so much. You can also support one of our staff members in our challenges for the month. We have someone doing some dance 8 counts every day. We have I'm riding my bike 350 miles for the month. I'm up to like 220 right now, so only 30 more to go before the end of the month. We have another dancer. We have somebody who's walking and making sure that they get at least 10,000 steps a day. So we're definitely focusing as a staff to bring attention to Black and brown artists and their mental, physical, and spiritual well-being. So thank you all for joining us tonight. Dr. Irvin, again, thank you. Mike,
thank you so much.
And we thank you all. Please join us for our future programming, and thank you for joining us tonight.
Thank you.